For this year's unit-based competency for both float pool and Unit 4, we're going to be discussing mucositis. This topic for competency came about from both Elaine and Anne wanting to look at our rates of mucositis, figure out how we could decrease both our rates and also the complications related to mucositis. So for today's discussion, we're going to be talking about complications related to mucositis, proper assessment and documentation of mucositis, and then mouth care. So what we can do as nurses to try to impact our patients and decrease the rate of mucositis. As most of us know, mucositis is an inflammation of the mucosal lining. The inflammation extends from the digestive tract, throughout the digestive tract, so from the mouth all the way down to the rectum. Mucositis is caused by the chemotherapy or radiation from the chemicals of those two treatment modalities getting into the blood vessels of the digestive tract in the mucosal lining and then causing a breakdown of those healthy cells. So as we know, chemotherapy attacks not only the cancerous cells or the white blood cells, what we're trying to kill off, but also healthy cells. So it attacks the mucosal lining, thus causing a breakdown within the lining. That lining can cause the breakdown of the lining, then causes the mouth sores that we see, and then it's important to remember again that goes all the way through the digestive tract. So we have both sores and also inflammation. So not only can mucositis cause the mouth sores that can get infected, but can also cause an inflammation of the airway. So that's why some of our patients have respiratory concerns as well due to the inflammation of this mucosal lining. In articles that I researched, 80 to 90% of transplant patients have this complication. So this is something that affects most of our patients. And I think that on Unit 4 and on Unit 5, the patients who are getting high dose chemotherapy, this is a really common and detrimental side effect that they get from the treatment. So we're looking into how we can kind of decrease that number, and maybe we can't stop mucositis, but how can we stop the spread of it, the severity of it, and the complications related to it. So now we're going to touch on the why this is important, and this is kind of the big hitter of the topic for today. So we want to change our thought from this is something that all of our patients get and change it to kind of how we can try to prevent it and how we can make it less impactful for our patients. And these are the reasons why we want to do that. So mucositis is related to an increased infection rate. This is one of the biggest things to keep in mind. It's related to increase in sepsis rates, and we'll touch on that. And this is kind of, again, the big why this is important. This is kind of the big one. Increased use of opioids. As we know, a lot of our patients with mucositis are in severe pain, so they use PCAs very frequently for this. Patients who are old enough, and in the research I read, that were able to discuss that pain say that the PCA doesn't really help the pain, it more just sedates them. And I think that most of our patients on 4 and 5 would also agree that it's not that helpful because the pain is so severe that it more just kind of masks the pain and sedates the patient. Increased length of stay. So when we have an increased infection rate, increased pain, we're on opioids, we're waiting for those mouth sores to heal. That can prolong how long patients are here. This also ties in with oral aversion. So when you think about getting a mouth sore and having that all the way through the digestive tract, a lot of our patients have an aversion to even swallowing their saliva. So we have to kind of retrain them to even swallow their own saliva rather than suction it or have it or just spit it out. So this is something also to keep in mind of how it impacts our patients. Increased readmissions, we'll touch on the increase in infection rate and how that can impact our readmission rates. And then increased cost of stay, we'll talk about the cost related to mucositis. Loss of treatment plan track, so when we have patients who are getting multiple rounds of chemotherapy or radiation, when they get such severe mucositis that they're having to, retrain themselves to be able to take oral meds or get off pain medicine, things like that, or have an infection, then sometimes their treatment is prolonged, which is, of course, not something we want to happen. Also, this is related to increased C. diff rates. So when you think about some of our major goals on the unit each year, we're always looking to decrease infection We're always looking to decrease our C. diff rates. So you can see how important mucositis is and how it really ties into some of those big hitter goals that we have to impact our patients. C. diff rates can go up with mucositis because we have that breakdown of the digestive tract causing those open sores, and then we have now an infected area of the mucosal tract potentially leading to C. diff. So we have areas where the infection can easily enter into the bloodstream. As I touched on, one of the big things here with mucositis is the increase in infection rate. When we look at how the CDC categorizes CLABSIs, they have two categories. They have one that's a bloodstream infection, not from a mucosal barrier injury, and then they have what's called MBI, LCBI, mucosal barrier injury, laboratory confirmed bloodstream infection. So what this means is when we have a patient that has a fever, we draw blood cultures, we send it to lab, and they call us back with a positive blood culture, and then they tell us the organism. If it's an organism that lives within the digestive tract in the mucosal barrier, it is categorized differently than if it doesn't. So a lot of times when we think of our patients getting fevers and having sepsis risk, we think of them catching something from somebody outside. So we think of maybe their family member or their little sibling coming in, catching something at school, transferring it to the patient, or lack of hand hygiene, something like that causes an infection to spread within our neutropenic patients. When in reality, a lot of our infections and CLABSIs are coming from within their digestive tract. So what happens is the breakdown of the mucosal causing mucositis lets in infection, and then that transfers into the bloodstream. And this can be really detrimental to patients. So we have it categorized differently, whether it's coming from the mucosal tract or not. In 2018, this is from Unit 4 and Unit 5. I'm not exactly sure their numbers, but overall, in general, studies show that majority of BSIs and the positive blood cultures we're getting in transplant and neutropenic patients receiving chemotherapy is over three-fourths of them come from mucosal barrier injuries. So like I was saying, on Unit 4, we had 11 of them in 2018, and I believe total we had 15 in positive blood cultures. So pretty good, or a pretty significant amount of them, not good. In 2019 so far, we've had 5 mucosal barrier injuries and total of 7 positive blood cultures. So this is a really significant number, and it's also important to highlight that if we can decrease this rate, we could really make an impact for our patients. So if we can get our mucosal barrier lining cleaner and prevent infection from spreading into the bloodstream, we could really impact our patients. That would be over three-fourths of our patients who would not have had a positive blood culture this year if we could try to decrease that severity of the mucositis. So as I was saying, a lot of the literature shows that most of the BSIs in positive blood cultures are coming from these mucosal barrier injuries. So a study assessed 1,000 BSIs in transplant patients, and 71% were MBI, LCBI identified, meaning 71% of those positive cultures came from an organism that lives within the digestive tract. Things like E. coli is an example. So just thinking of how we could decrease the spread of that to then decrease it going into the bloodstream. As I was saying, the sepsis risk really increases with mucositis. So there's a significant increase in the sepsis risk when there's just neutropenia versus neutropenia and mucositis. So we expect that all of our patients getting chemotherapy and radiation are going to have neutropenia. So that's something we can't decrease because we want them to get neutropenic when they're going through treatment to kill off those cells. But what we can impact is the mucositis and the severity of it. Increased use of opioids. So mucositis has been dinged the most debilitating side effect of transplant from patients in research who are able to talk about their transplant and able to tell us, they're not toddlers, they're older patients and adults who can explain what the worst part is. And unanimously, people say mucositis. So we really can think about that in terms of making an impact on our patients too. If we can decrease the severity of it, how can we, or then we can help them be more comfortable overall. The effectiveness of opioids in mucositis treatment is questionable. Like, as we touched on, majority of it is just like sedating the patient or, trying to kind of help them forget it, it doesn't necessarily do a great job of taking the pain away, and it certainly doesn't treat anything. Long-term use of opioids, as we know, can lead to further complications, and then, as we touched on, there's just a lack of treatment. So this isn't a treatment modality, but it kind of helps to mask the side effects of mucositis. Increased cost of stay. The estimated cost related to mucositis is around $8,000, and this cost doubles when the grading of mucositis increases from mild to moderate or severe. And as we'll touch on in a little bit in coming slides, majority of our patients who get mucositis do have the moderate to severe form. So by the time we figure out they have it, and with the chemotherapy and radiation agents that our patients get, majority of them have a pretty severe form of it. And then increased cost of stay can be related also to readmission rates due to mucositis. Risk factors for mucositis, the dose and frequency of radiation. So a lot of times we think of chemotherapy as being the cause for mucositis, but really radiation can have just as big of an impact on that mucosal lining. Poor oral hygiene. So as we'll touch on, one of the best things we can do for our patients is to help decrease the severity of this is to clean their mouths out. The type of chemotherapy. So 3 of the big hitters in the research are methotrexate, melphalan, and Cytoxan. And these are all ones that are frequently used here in our hospital. So methotrexate, melphalan are used a lot up on Unit 5 and some on 4 too for certain protocols. And then Cytoxan, which is almost, strong majority of the Unit 4 patients get. So it's important to think about that too. So our patients right off the bat have a lot of these risk factors identified if they're getting one of these 3 chemos. The dose of chemotherapy, a lot of our patients are getting the high dose chemo with their transplant or with their chemo upstairs on 5 too, so they're at higher risk for mucositis. History of periodontal disease, this one is questionable with our patients because most of them don't have a strong history of periodontal disease at their young age, hopefully, but it kind of goes along with the poor oral hygiene. And then males are slightly more at risk than females. Prevention and treatment. So there currently is no treatment for mucositis. As we know, once our patients get mucositis, we kind of just have to wait for their counts to come in for them to really have an impact and feel better and really have a benefit to what they're experiencing with the mucositis. But what we can do as nurses is practice early assessment and detection of the initial mucosal breakdown so that we're keeping track and we're aware of when that kind of begins and we're looking for spread of infection. We had a patient recently on Unit 4 who had a pretty significant super infection in his mouth, and there was question of it being a fungal infection at the time, and so really diligent assessment of that helped us to identify it before it got even further out of control. We got ENT involved and got things rolling, and so making sure we're actually looking in the patient's mouth and aware so that we can keep track of anything that's looking like it's really getting infected, as we know that can spread very rapidly in our patients. We already touched on frequent assessment for worsening sores, and then early detection can also help with more successful pain management too. So, as we said, there is no definitive treatment, but we can prevent the spread of infection due to mucositis. We may not be able to prevent the mucositis from occurring in the first place, but our goal is to prevent the severity of it and ultimately the infection related to mucositis. So mouth rinses in the literature are the most effective prevention technique and the most likely to decrease infection, or the most likely intervention to decrease infection related to mucositis. The literature shows that saline is the best for mouth rinses, but others can be used. There's other things that can be used, such as Biotene or Paradex. Those are just fine too. Some patients have a preference on the rinse that they use, and that's fine. The other one that's frequently used is Magic Mouthwash, and that's the one with lidocaine in it. And so that one, I think the goal with Magic Mouthwash is to have is for more pain relief because it has the lidocaine in it. So the goal would be to use both that and saline, like a combination of it, so that we're still using the saline to rinse out, to clean out the mouth. But if they're not going to do that, then at least, if we're at least using the magic mouthwash, to use some kind of rinse in the mouth. That's what our goal is. Other treatments in research. So as we said, mucositis is the most debilitating side effect of transplant, and because we don't and high dose chemotherapy in general, because we don't have a treatment, and we know it's the most debilitating, it's a really hot topic in research, trying to come up with something to offer patients that they can that can decrease the impact of it. So a couple of these things that you may or may not heard of are cryotherapy, aloe vera, and glutamine. There are others out there too, but these ones are ones that maybe we've heard of, so we'll just touch on them. So glutamine is a mineral that kind of coats the mouth, and then the goal of it is to create a barrier in the mouth and the digestive tract. There is no benefit to it that has been shown in the research, but a lot of our patients, sometimes frequently who come from children's, will add it to the regimen. They might have heard that it might make an impact, and so the providers are willing to try it. It doesn't show an improvement, so we're not going to switch all of our patients to glutamine, but it is there in case, or if you see it there, I should say, it's likely because a family has requested it, and it's not something that is a risk to our patients, so it's something that, if they request it, it's not going to harm the patient, but it's likely not going to cause improvement. Aloe vera, there's some research about using like aloe vera rinses to kind of create a protective barrier. Again, sort of the same idea. The research there has shown like a 5% improvement in some research. Others have shown no benefit. So that's, again, something we're not going to switch all of our patients to. The one thing that we may look into more is cryotherapy. So the cryotherapy is a treatment that, a preventative technique that the idea is to keep the mouth cold before, during, and or after chemotherapy infusion. And this one, there has been some shown benefit, but there is a bit more research needed, which I'll touch on in a second. So the idea of cryotherapy is to keep the mouth cold because the coldness makes the blood vessels constrict in the mouth, reducing the amount of blood containing chemotherapy drugs from reaching the mouth. So if we're constricting those blood vessels, we have less blood cells that contain the chemicals of chemotherapy and radiation, thus less of it spreading. So the evidence out there has shown that there's a decrease in mucositis rates and severity of it using this with high-dose melphalan and methotrexate. So those are, as we know, two of the most severe mucositis agents, and so they're looking into these first as research. The areas where there needs to be more research is on the timing and frequency of this cryotherapy. So sometimes the research says to try it before, for 10 minutes before the chemo starts to shrink the blood vessels. Some say during it, and others say after. The problem is some of our chemos run for 2 to 4 hours, so we're not going to be able to have our patients keep ice in their mouth or something cold for 2 to 4 hours. So it's something that we probably will include in our care plans here moving forward once we get a little bit more of an idea of what we want to do with it. Whether we just try it for 10 minutes before, 10 during, and after, and see if we make an impact. And we could use ice, something like a cold drink, popsicle. Of course, we'd need to figure out the ice situation for the Unit 4 kids. A slushy, Diet Shasta, something to just constrict those vessels. So something to be aware of and something that moving forward we might include. But we're going to continue with our mouth cares as our mainstay of prevention for that infection. So mouth cares, the expectation is 4 times a day. And for float pool, it's important to be aware too that Unit 5 their local council is looking into this too because they don't really have a set plan for mouth cares on their unit. So trying to include that in the care plans of their patients, and they're looking into what we do as far as prevention. So we're kind of all working together too. So mouth cares will be done 4 times a day. The other thing we're going to really increase is our education we give to families. So when patients are admitted, we have an admission packet that we go over with them. Unfortunately, within that admission packet right now, there is only about 1 or 2 sentences that states we will be doing 4 mouth cares a day, and it doesn't explain why or give any insight into what that's going to prevent. Hopefully, nurses right now are kind of touching on that with patients, but it's not something that's in the packet, and it's not something we really focus that heavily on. So we really want to switch that culture into providing families with sound education on this. So now that we're all going to be educated on mucositis and how we can prevent infection with having a clean mouth and using mouth cares, we can hopefully transfer that onto the families. So some things we've talked about in other groups that I think have been very insightful and helpful for everyone are ways to have increased compliance with our patient families. So one of the things is, so moving forward, I should mention, there will be a handout within our within our admission packet that just talks about this education with the families. It talks about what mucositis is, how to do the mouth cares, what the mouth cares are, and what that might prevent. And so what we want to do is try to get our families on board with the 4 times a day and really have them kind of take ownership of it. So we want them to think of these mouth cares just as simply as they do washing their hands. So it's something they would never not do. And so we want them to think of mouth cares the same too, that we always do 4 times a day. We're trying to decrease the severity. We're trying to decrease the spread of infection. So we really want to try to help our families understand why this is so important so that they can help their children also. So our job will be to educate families using the new handout. And as I said, in other groups, we've talked about how we can include families in this, like explaining to them this is something you can really take ownership of. So explaining to families, there's going to be a lot that you can't control here in the next, month when your child is here. But this is something that can really make an impact on your child and something that you can do while you're in the room. And a lot of families, I think, will really appreciate that because, they come into this situation and they don't have a lot of control over the care of their child or the health of their child. And so framing it for the families to really have something that they can make an impact on will be really helpful for them. Let's see. So we're going to start using the handout during our admission. So when they first come, we're going to give the handout. We're going to go over that. That will be part of our education. And then having our nurses who, if you come on and the patient's only been here for a day or 2 or 3, really reiterating with them this education, because this is probably something that they're going to think, we came yesterday, we got all this information. This is maybe something that is new to them and they're not aware of. And so we really want to, set that standard from the get-go. So as I said, if they just got here a couple days ago, it'd be really crucial to go over it again, maybe, or start coming up with a plan with them. Do you want to take control of this? Do you want me to do it? When's a good time? That kind of thing. So that's something that we can all get better at is, touching base with families shortly after admission to see how they're doing with this and answering any questions. A couple other points that have been talked about too that I think have been really, really great is, and how we like to try to transition. Nurses who have been here for a while have mentioned that when they first started, mouth cares were just part of the vital signs. That was just something that was expected and we just did, and it was just like you would never not grab a blood pressure Q4 hours, you would never not do a mouth care. There was kind of a non-negotiable. And we've gotten pretty far from that, where we kind of either forget about it, or we think families are doing it, or they don't want to do it, and so we don't want to push them to do it. And so our hope is to get closer to the expectation of it and just getting it done, because it really can be valuable to our patients and their outcomes. So we'll talk about proper documentation of this on our PCS. Other ways we've talked about, so then our next kind of question here is how to increase compliance. So when we did a chart audit of how many mouth cares should have been done on patients, so taking the 4 times a day and looking at how many were actually charted, we were 19% compliant. So we have a huge improvement gap here to make. So we'd like to get that closer to 100%, of course. So some ideas that people have mentioned on how to increase compliance. And then if you guys, I'd love for you to chat among yourselves about other ideas you have. But Some ideas people had included doing it with the vital signs, just 8, noon, 4, and 8. That's just how we do it. That way we don't need to be doing it at midnight. Before or after medication administration, like 8, 2, and 8, and then add another time somewhere in there too. That's a really good idea. Let's see. Yeah, or like 8, 2, and 8, and then when they do a bath or something. I don't know. Just trying to set a routine with families. So when we're finished with this, with a presentation, this is something that we can start thinking about, is how to increase our compliance with that. Something else someone mentioned is, it's hard. Well, it's hard if they don't have a set time or a set schedule with it, for you to, keep saying, oh, is now a good time, and then we forget about it because we're adding a million things to our list of things to do, and we've got lots to do. So kind of working with families at the beginning, that's why if we start talking about it on like day 2, 3 of admission, then we're really setting a schedule and a standard with them, and that will help to kind of make it just part of the routine. We also have some people put boxes on the whiteboard. I think and then cross them out when they're done. I think the part that gets tricky with that is we don't always write the date. So then we're like, oh, is that from yesterday? Is that from 3 days ago? They have one done. Did they do it today? So if you're going to do the boxes, maybe just writing the date too, so that we're aware of that. And then just making sure they have the supplies, because if they're out on the counter, they're, more likely to do it. Also, not assuming that families are doing it. So kind of creating a discussion with the families that way. So proper mouth care technique includes a rinse solution. As we talked about, saline is the standard, but if there's a different mouthwash they prefer, that's just fine. If they don't like or have an aversion to the taste of the saline, then using some Diet Shasta was something Elaine mentioned. If you mix the Diet Shasta with the saline, that kind of drowns out the taste and also can help to get the grime off the mouth and teeth. The Shasta can. Just make sure we're not using regular Shasta. That's sugary. So we want to use swabs to clean the mouth. Our patients a lot of times have low platelets, and so once they start chemotherapy, they're not allowed to use the soft toothbrushes anymore. Up on Unit 5, it may be a bit different. But typically use 3 to 4 swabs, and we just want to make sure we reach all the corners of the mouth. So sometimes I've seen it where they'll use like ones, or what I teach families, and everyone can have a different technique, but just making sure you get all the corners of the mouth is doing like one for the left, one for the right, and then teeth and tongue and the palate. Right side and left side of the mouth, the buccal, cheek mucosa. But, as long as they're getting all the parts of the mouth and getting it clean, the technique doesn't really matter. So we also want to talk about using it as like an actual toothbrush too. So if our patients can't use a toothbrush for this whole time, you think about how grimy their teeth could get, and that can be a source of infection. So not only do we want to rinse their mouths with rinse their mucosal lining with the saline and swabs, but we want to start using it as like a toothbrush too if they have teeth. So someone from Flowpool's husband is a dentist, and she mentioned, it's not so much the solution or the brush that you're using, it's the friction. So breaking up the caries on your teeth can really help to prevent infection. So we want to start doing that as part of our routine as well. So, if you think about a lot of our patients, what they like to eat, if they like to eat anything, is candy during transplant. And then a lot of times the solutions that they take for their medications, their oral solutions, are very sugary. So we want to try to rinse out the mouth and also scrub the caries off the teeth as well. So for documentation and mouth cares, there's a couple different places where it can go. I believe it was on the survey that talked about there's a couple different areas where people are doing it. And when we went through and did the audit, we did take account for wherever people were placing it. We did count that, but we'd like to try to keep it in the hygiene care under oral care. In the complex mucositis scale, where you will chart your full assessment, there's a place for it too. But this way, if we're doing it under hygiene care, NSTs can do it as well. And so they're really a key factor in increasing our compliance as well, kind of teaming up with them. And, do you want to do one at 8? I'll do one at noon, or at 4 and 6, or 4 and 8, whatever. Just planning planning your day out with your NSTs too, so that we get them on board with completing mouth cares as well. So our assessment of mucositis, we want to get 2 full and complete assessments each day. As I touched on, the patient that we have right now who had a pretty large infection in his mouth, he, had we not been looking in his mouth, we wouldn't have caught that, and things could have been much worse from that mouth sore. So again, although a lot of our patients do get mucositis, and we know they're going to, so we don't want to just blow that off and not assess it because everyone's going to get it, because it can get really out of control, and infections can really spread quickly in that broken down mucosal injury or mucosal barrier injury. So we want to be using the complex mucositis assessment, and that needs to be wrenched in the GI section on the PCS. So we'll do 2 of them a day, and I think when Epic upgraded a while ago, it got put in maybe a different place. So when we went through the audit of the assessments, some of our patients didn't have this. So we want to wrench it in from the GI section under complex mucositis scale. And then it's right over here is how we want to be using it. And then filling that out twice, or doing a full assessment in the mouth at least twice a day. And then otherwise, if they have like one bad looking sore or something, just making sure you're looking at that more frequently so you can do a focused assessment. But twice a day, we want to look fully in there. And it's also important to think about their lips too. That can be a really quick source of infection. If it starts on the lips, it can very easily spread throughout the mouth in that mucosal lining. So this was a place that people were doing the documentation of assessment if they weren't wrenching in the complex mucositis scale. There's an oral mucosa symptoms under HEENT. So we want to make sure we're doing it under the complex mucositis scale, because this is just much more detailed and goes more in depth. So mucositis grading, this is not how we necessarily grade it on our complex mucositis scale, but it is something to take note of and just be aware of. So the World Health Organization assesses mucositis on this oral mucosal grading scale. Grade 1 is just oral soreness and erythema. Grade 2 is when they begin to have ulcers. Grade 3 includes ulcers with extensive erythema and unable to swallow food. Mucositis to the extent of any sort of nutrition or liquid or swallowing food, and even swallowing like your saliva is not possible. And then grade 5 is considered death. So you think about our patients here who have it, a lot of them are grade 4. Many of them get to the point where they don't even want to swallow their saliva. Most of them get to the point where they don't want to swallow food and drinks. So we're already at 3-4. So we're at our patients are at about as significant and severe of mucositis as they can get. So we have much of area of improvement. So we'd love to get up to here where they just have some soreness and a little, maybe 1 or 2 ulcers. So this is, of course, regular mucous membrane, and this it's considered advanced already when they have one broken down area like that. So the soreness and erythema under grade 1, all the way to the tongue with those open sores. When you see under grade 3 here, you see this white coating. This is plaquing, and when that happens, we're about to get to this. So that's kind of where the lining is losing its integrity, and then it's gonna easily become broken down after that. So that's something to take note of in your assessment. So the components of the complex mucositis scale, these are things we just want to make sure we're looking at it at least twice a day. We want to get the buccal mucosa, which is the cheek, the lining of the cheeks, the soft and hard palate shown up here, and then the lips, the tongue, the teeth. You want to make sure you're looking at all of that. And here we have, again, some of that plaquing and then sloughing of the tissue here. And this is what most of our patients get to. So why are these documentation and mouth care so important? Again, we want to decrease the impact of mucositis on our patients and try to start decreasing the severity of mucositis. So again, as we touched on, the CLABC versus MBI, LCBI. So if we can decrease our severity and infection of mucositis so much that we're decreasing the transfer of infection from the mucosal barrier into the bloodstream, we could really make an improvement in these patients' outcomes and lives. So we want to try to prevent the spread of infection. So by using the mouth care rinses, we can keep the mouth clean, which in turn will help keep the whole digestive tract cleaner. So if we're stopping the spread of infection in the mouth, we're stopping the spread of infection through all the way down through the rectum of the mucosal barrier. Proper assessment can show that we have done our due diligence. We are looking in the mouth to keep track of the spread of infection. And then we want to show our documentation of mouth cares because it shows that we're properly intervening for these patients. As we touched on, there are some other interventions that are out there in research. But before we move to anything like that, we want to take note and see, are just doing mouth cares effective? So we have kind of our rates of MBI, LCBI for this year. And now once we start hopefully really increasing our education with families and increasing our adherence with mouth cares, we can really hopefully make an impact. And then we can look back at our rates and say, oh, now for the last half of the year, we have much fewer infections related to mucositis. So we want to make sure we're doing our standard of care, and then also that way we can look back and see what kind of impact we're making on our patients. So again, the care goals of mucositis will be understanding the importance of mucositis and consequences of it, which hopefully you guys do now after this education. We want to transfer this education onto our patients and families. So we really want them to understand the importance of it. I think as nurses, we do better when we understand the importance, and I think our patients' families will do just as well if they understand the importance of it. Something also to take note of is the patients who really, and this is something we can tell our families too, is that patients who are very adherent with mouth cares are typically patients who have had mucositis in the past and they don't want it to become as terrible as it was, and they know the impact and how painful and how impactful it can be on infection and everything. And or else it's families who maybe have heard from somebody else, oh, this is really bad, this is what you don't want to happen, things like that. So that's stuff we can educate our families on too. We've heard from patients who are able to tell us that this is really terrible and they don't want it to happen. So we'll work on educating patients and families on proper mouth care techniques and why it's important on admission and the days following. And then again, really starting to get in a routine with our families when they're going to do mouth cares. So lastly, if you could just discuss some points that you could use that you've maybe learned in this section here. What are some points you could educate families on when they admit to Unit 4? And then also, what are some ways you think we could increase our compliance with mouth cares? So if you have some time to discuss now, and then if you have any questions, please email me, let me know any ideas you have, and hopefully we can make an impact. Thanks.